New Disabled South presents.
This is like a job worrying about this stuff, and we should have that burden lifted off us. We have so many burdens in our lives. We deal with so much each and every day, especially right now. Like this past month, April was like the worst for me. So why do we have to worry about this more? Why do we have all these limits?
For over 12 million Americans, being disabled means more than managing a diagnosis. It means managing inaccessible systems built on Medicare and Medicaid, programs not designed to work together, yet millions are compelled to rely on both. They're known as dual eligible or dual enrolled. They are among the most economically disadvantaged and medically complex people in the country. Nearly half live in poor or fair health. Many are people of color. Some are older adults who spent their life savings to afford long-term care. Others have been disabled since childhood or pushed out of the workforce by illness or injury. They make up just 17% of Medicare beneficiaries, but account for a third of spending. Why? Because their needs are greater, and so are the gaps in the systems meant to serve them. In theory, dual eligibility should mean more coverage that reflects and meets the critical needs of those who qualify. In practice, accessing services is a labyrinth, one where the dually eligible are forced to navigate the punishing reality of conflicting rules, denied care, bureaucratic delays, and provider shortages, especially in the South. The cost of getting it wrong, their health, their livelihoods, their stability, and their futures. That's why we're telling their stories, the way these stories need to be told. I'm Stacey Abrams, and this is Dual, the true cost of care.
Dual, the true cost of care.
Kayla lives in Georgia. She's one of more than 12 million disabled people in the U.S. who rely on both Medicare and Medicaid, what we call dual eligibility.
Social Security found me disabled in 2013. So I think I had SSI at the time. I was like 16 years old. I got on SSI in the first place because I'm autistic, and I've known I was autistic basically since childhood. I was diagnosed with PDD at age 2.5. And, the DSM got updated and PDD is no longer diagnosis, so it's just autism. Basically, I'm like a mild support needs autistic person. And it doesn't mean I don't need support. I do need quite a bit of support. I mean, I could do some things on my own, but I still need my mom's help for a lot of things, or somebody's help. I didn't get diagnosed with ADHD back then because autism and ADHD couldn't be diagnosed together until 2013 when the DSM got updated. That also got rid of the PDD diagnosis. So I didn't know that. That was kind of a shock to me that I had both. So I'm IUDHD. I guess that's how I was eligible. And also what helped was I'm a type 1 diabetic. You see I have a continuous glucose monitor on my arm. I was diagnosed with that when I was 8 years old.
This level of medical complexity, autism, ADHD, type 1 diabetes, along with PTSD and OCD, makes Kayla exactly the kind of person dual eligibility was designed to serve. People with multiple conditions who need both the federal benefits of Medicare and the long-term supports that Medicaid can provide. To understand why the intersecting systems are so confusing, we spoke to Dr. Carrie Graham. She's a health policy researcher at the University of California, Berkeley, who has spent decades studying how Medicare and Medicaid work and how they don't.
Medicare is a program that is available to all U.S. citizens who've worked for about 40 quarters and who have paid into Medicare. And you get Medicare either when you turn 65 or if you have a disability. Medicare does not pay for someone to come in and help you take a shower. They do not pay for meals being delivered. They do not pay for things we call long-term services and supports or personal assistance services. So Medicaid, it's essentially health insurance for when you're low income. If you are dual, or you might hear the term Medi-Medi, it means you have Medicare and Medicaid. There are two programs that were not meant to work together.
For Kayla, getting that coverage wasn't a moment of clarity. It was the start of a long, confusing journey.
So like 2018, I don't know how I got there, but I went to the Shepherd Center. And there was this great woman, I think her name was Sally. Sally gave me a Medicaid card, the blue card. And I think that's when I got enrolled in Medicaid.
That disconnect between the two programs showed up almost immediately.
Problem is, it's only if you go to doctors that accept both the Medicare and Medicare Advantage plan and Medicaid. So for example, if I see somebody who only accepts Aetna Medicare, but doesn't accept Medicaid, then I would have to pay the remaining balance. And that's what's kind of been the difficulty for me, because sometimes I find in terms of mental health, there's barely any that take both. And most of the ones that do, take Aetna Medicare, but they don't take Medicaid. So that's been my problem.
When Kayla needed help understanding how these programs work, she found herself navigating a maze with no map.
It was really a challenge. It was I wish someone would have told me this right away. Because Sally was great. I don't know if you mentioned it or maybe I just forgot, but it was, I've mostly found this stuff out within the last couple of years, last 2 or 3 years. And it was really, really stuff to figure out on my own. People were giving me conflicting information, even people from Social Security and were giving me conflicting information. It's hard to call on the phone because you have to get a call back and it could take all day and all that.
Aisha Adkins is a caregiver and advocate in Georgia who knows the system not just professionally, but personally. She spent years navigating dual eligibility for her mother, who lived with dementia.
I think the most misunderstood factor when it comes to dual enrollment, I think, is that any of it's automatic. I think that, certainly with Medicare, there's this understanding that, that first of all, that it covers everything, and that it's this just automatic process that takes place once you turn a magical number age, and then that Medicaid is something that is very easy to apply for, that it's something that is easily accessible, and unfortunately neither of those things are true.
So that's been difficult to figure out, and just people have been telling me different things. And then Medicaid, it's been really even more difficult because it's really hard to talk to somebody, to reach somebody in Georgia. It's really, really difficult because nobody is on the phone to answer your questions. You have to wait a long time, or you don't get anybody. You don't even know the right department to call. At the Medicaid office, they were nobody can answer we can't answer your questions. You have to speak to your counselor or something. So it was just really, really difficult. Finally, I've been talking to somebody. She's been really, really helpful, but hopefully she knows, and she's been answering my questions, but she's the first person I've really been talking to on a regular basis about my Medicaid questions. But yeah, it took me a long time to get to there.
After years of dead ends and conflicting information, Kayla finally found someone who could help. One knowledgeable, caring professional who took the time to answer her questions. It shouldn't be remarkable, but in a system designed to exhaust you, finding someone who actually helps feels like winning the lottery.
I wish also all this information would be presented to somebody up front and not be found through so they can't find it on their own through the internet or what.
This is what the system could be if every person navigating dual eligibility had access to someone who understood both programs, who could translate the bureaucracy, who saw them as human beings deserving of care. But for most, that support never comes.
I keep calling and calling, and I get nowhere, and it's just hard looking all this stuff online. Like, I found most of this stuff like online. I had to find it out on my own. And that's a really scary thing, because I was like, oh my God, what if I went over the limit this month for my monthly income? And the thing is, like, it's all been very, very difficult to find on my own. It's been overwhelming, very stressful, bad for my mental health. I get scared, like, oh my God, I have to pay all my money back or go to jail, which nobody told me any of this stuff.
That income limit isn't just a worry, it's a trap. One that forced Kayla into an impossible decision. It's a story we've heard quietly again and again, but speaking it aloud comes with risk.
That's why I asked my boss, like, yeah, can you pay me a little less so I could be under the limit? And you shouldn't ask that. I mean, the minimum wage being low as it is, like, I was getting, it was good pay for what I was doing, and I had to ask that. And
this is what the system demands, that people work less, earn less, live with less, just to qualify for care. For Kayla, the burden of figuring it all out without help became a full-time job.
And people think, like, oh, this is like free money you're getting. It's not. I mean, you know how expensive it is to be disabled? Do you know how complicated this is to navigate? This is like, for me, it's like a job navigating the system.
When the system breaks.
The bureaucratic maze of dual eligibility becomes truly dangerous when you need the system the most, especially during a mental health crisis. Because for people like Kayla, barriers to mental health care access quickly become debilitating.
I'm a person who has trauma, and I've been very depressed. I'm not ashamed to say it, like, I have PTSD, like chronic PTSD or complex PTSD and OCD, like I said, and depression and anxiety. So it's been very hard to, like, find what I need.
Kayla knows what kind of therapy could help. DBT for emotional regulation, EMDR for trauma, a provider with experience working with autistic patients. But finding someone who accepts both her Medicare and Medicaid plans and offers care that actually helps has proven nearly impossible.
I need essentially, like, DBT, because I heard DBT helps with emotion dysregulation, which I have. I also want EMDR, which will help me with my trauma, processing and healing from my trauma. But to find somebody that does both and accepts both my insurances and also has experience working with autistic people, well, that's not a big deal for me, but still, is like in a blue moon. In states that have expanded Medicaid, because you might know that Georgia is one of the 10 states that has expanded Medicaid. Even in the states that have expanded Medicaid, I saw an article or a study that, like, even in those states that have expanded Medicaid, the doctors haven't increased. The fact that so little mental health providers take those insurances is just, like, a big problem, because, like, I just want to ask them, like, you think that disabled people can't be mentally ill? How can we not be mentally ill sometimes in the ableist, capitalist hellhole we live in?
And for Black, brown, and multiply marginalized disabled people, the stakes are even higher. Nearly half of all Medicare, Medicaid enrollees, 49%, are people of color, compared to less than 20% of Medicare beneficiaries without Medicaid. Black enrollees make up 22% of dual eligibles. Hispanics make up 20%. The barriers compound. Ableism meets racism meets poverty, creating deeper inequities in communities already fighting for survival. For autistic people like Kayla, mental health care is often inaccessible. And when it is available, it's rarely tailored to their needs. Aisha Adkins has seen how these system failures affect entire families trying to navigate care.
The fact that these systems don't cooperate, they don't speak to one another, also makes it challenging when you're attempting to ensure the continuity of care, right? And you're unable to do that when these systems aren't working in tandem. And that's really frustrating as well.
Without access to providers who take both plans, Kayla faced a choice no one should have to make, and millions cannot afford to make. Go without care or pay thousands out of pocket.
Like, I had to go to an eating disorder IOP once, and I had to pay all of it out of pocket because I was in a really crucial time and I needed it.
But the most devastating gaps appear when inpatient care is needed. Yet, all that's available is whatever facility takes your insurance.
When I've been in inpatient, like, okay, so trigger warning, I've tried to, I've been in crisis situations before, I'll just say that. When I had to go to the hospital for that, I went to hospitals that were really, really terrible. Like inpatient, like I've had to stay in really, really bad places. I didn't have a choice. I mean, in all these places, inpatient, the hospital, the emergency room people just decides where you go because what's available by insurance.
One facility was Summer Ridge, where Kayla was admitted in 2020. What she witnessed in just 1 week reveals the difference between healthcare and institutional warehousing.
I don't know, there were fights. There was pee on the floor. Someone peed in a chair. Someone peed on the floor. I saw someone naked without my consent. I was bullied by the patients. There were fights, a lot of yelling. I saw sexual harassment. Somebody who was diabetic there, like me, had something wrong with her blood sugar and had a little crisis, but then they didn't do anything. I saw all of that within a week. The shower wasn't working. It was overflowing. I was having my cycle and they didn't have pads like that fit, and the clothes didn't fit, and it was scary because all the yelling, all the fighting, all the running away. I even saw like a patient like try to physically fight with the staff. All that happened within a week, like everything I just mentioned. That was a very traumatic time, and I was called a bitch there by some of the people there, some of the patients there. And I was like, somebody's stealing my stuff, right? And like it was found out like my roommate was stealing my stuff, and then I walked in on her stealing my stuff and she was naked, and this was without my consent, and oh my God. It was just so atrocious. I want to do something about that place.
These experiences taught Kayla a devastating lesson. The system designed to help her could cause more harm than healing.
Like, because mostly I'm on these places for a week, and that's all I ever want to be, because these places are even less because these places just suck. I pretended I was okay, I was getting better so I could leave because these places were hell. People always say, like, if you have a crisis, you call 911 or go to the hospital. But I mean, I could talk about, this is a whole other subject, but I've learned not to do that anymore. Like, even if I'm in danger, like, of myself, I would never call them because I don't want to go back to a place like Summit Ridge or...
Carrie Graham explains why this two-tier system of care exists.
A lot of doctors don't take Medicaid because it's just too much of a pain in the butt and they're not getting reimbursed enough, or all these different things. So if you're in a rural area that already has a provider shortage, you might be required. I know in California, it's like people from rural areas have to go into Los Angeles or San Francisco to get certain kinds of specialists. How are you going to travel? Do you need a personal care assistant to come with you on that trip? How are you going to pay them for 24-hour care? So
I should be able to go to IOPs or PHPs or a residential place. I'd rather go residential than inpatient, but I deserve to go to these high quality places and not some fucking institution that'll treat me like shit.
However, opting out is not a viable choice. Kayla's life depends on access to insulin and continuous care.
I'm a type 1 diabetic, and I need health insurance because I have to get insulin. Insulin has been very overpriced in this country. It's the United States of America, and it's horrible. I think we have the highest insulin prices in the world. Medicare and Medicaid are good for medical care, but they're shit for mental health. But again, it's all about who accepts the insurance, right? So it's just been really, really difficult to navigate, especially when I don't have a choice. I need insurance to survive, unfortunately.
The trap.
It might be tempting to understand Kayla's story as an individual tragedy, but that's a convenient fallacy. These failures and gaps are known and they are systematic. Dual eligibility not only fails to provide adequate and necessary care, the complexity and contradictions actively trap people in poverty, dooming them to repeat these cycles again and again and again.
Poverty trap is not a term I came up with. Someone had a few people have told me that. I think the reason why is like, yeah, you get healthcare and you could get these services for the waiver, right? But because, like I'm on a wait list, I'm not guaranteed these services, or at least I'd have to wait, right? I'm not guaranteed them right away. And you'd have to they don't tell you about it. You just find out. I found out about the waiver too on my own. The thing about the poverty trap is that yeah, you're promised healthcare and these services that can make your life easier. But then you have all these hurdles along the way, you can't get mental health care, including eating disorder treatments. You can't even see a nutritionist even for if you have an eating disorder, you can only see a nutritionist 3 times a year, once or twice a year. It's really atrocious. And it's also a poverty trap because you can't make over a certain amount of money and you can't save a certain amount of money. So it's a trap because you fall for all these sound great. I'm getting money each month that will help me. I could get these services, but it's actually into poverty because you can't make over a certain amount of money. You can't save a certain amount of money.
The income limits don't simply reflect bureaucratic hurdles. Instead, they signal poverty by design. The refrain, "get a job," fails to account for the catch-22 built into this vital but contradictory system. In Georgia, the Medicaid income limit is $2,900 a month. That's less than the average rent for a 1-bedroom apartment in most Georgia cities. And those limits haven't kept pace with inflation in decades. For Kayla, whose SSDI counts toward that limit, it means she can only earn a few $100s through work or risk losing the care that keeps her alive.
I feel with everything going on in the economy, inflation, stuff like that, I feel these income limits are unlivable. I think Medicaid is actually okay, because that's almost $2,900 a month. But I can't make that much on my own in a month because SSDI goes into that money, right? It counts towards that, so I can only make half of that a month, which is not livable. And B, what part-time job would pay that anyway? But even with those limits, it's how can anybody live off of that in this economy?
And for those on Social Security, the restrictions go beyond income. They affect who you can live with, who you can love, and whether you can legally marry.
SSI has a marriage penalty, but SSDI doesn't. However, the type of SSDI I have, which is disabled adult child, also known as childhood disability benefits, that does have a penalty, marriage penalty. In fact, if I get married, I'll lose my Social Security. Do they not think disabled people can be in love and get married and all that?
Aisha Atkins has witnessed how these structural barriers affect entire families trying to navigate the system.
Education is key. I think that there are so many things that people are simply unaware of and unprepared for, particularly those who are caring for aging loved ones or, folks who become disabled kind of unexpectedly, right? I think that additionally, just from a policy perspective, making sure that people have access and that we, the waiting lists are astronomical and people's lives are depending on it.
If I'm not living with my mom or my sister and I have to rely on Social Security, then I think I'd probably be in poverty. I probably would be homeless and struggling. And billionaires don't have a cap on how much they can make, but disabled people do. And I was thinking to myself, yeah, that's true. And I'm what disabled person I know is rich? like that. I don't see any disabled rich billionaires in the world.
The system forces disabled people to prove month after month that they are still poor enough, sick enough, and dependent enough to be worthy of care. Improvement is punished. Progress is penalized. And yet Kayla, like so many others, keeps showing up, keeps fighting.
Disabled people should make as much money and save as much as we can, just like everybody else, and even more so because, like I said, being disabled is expensive. We deserve a meaningful life, all of us. And whether we contribute to capitalism or not, it shouldn't impact that. Everybody deserves to live a good life, right? That's what I think anyway. But even if we can or can't, it doesn't matter. We should all deserve a chance to have a good life and get the supports we need and get the resources we need to survive. And again, why do autistic people or anybody have to contribute to capitalism to prove that we deserve a good life? I'm hoping that things are able to change even with this administration. I hope we could still make policy changes somewhere.
A system that breaks people by design.
Kayla is 25 years old. She depends on Medicare and Medicaid, not just to stay healthy, but to stay alive. Yet the systems meant to provide that care are riddled with contradictions, red tape, and rules that punish the very people they claim to protect. They deny care. They limit income. They penalize marriage. They criminalize survival. This is what it means to be dual eligible in America.
Yeah, I just want people to remember, sure, we don't have true marriage equality. Yes, as of right now, we have marriage equality for gay people, and I'm a lesbian, so I appreciate that. But we don't have true marriage equality because disabled people, if they have these services, disabled people can lose them if they get married, and that's messed up to me.
Kayla isn't content to merely survive. She is organizing. She's speaking to lawmakers. She's pushing for change because she believes a better system is possible. Access to life-saving resources that doesn't ask people to trade dignity for care. But even in a system built to wear her down, Kayla is organizing, still showing up, still speaking to lawmakers, proof that disabled people are already leading the fight for a more just future. That's not optimism. That's survival as resistance.
I want to try to live as much as I can. I want to at least be able to live a bit in this life, right? That's what life is, to live, right? That's what it should be. But no, we're just surviving and worrying about all these barriers and limits that were put upon us for no reason. I really hope that changes in the next few years. I hope some change can still be done.
Dual eligibility was supposed to be a safety net. But for millions like Kayla, it's a tightrope, stretched across systems that were never built to hold them up.
I think the most important thing for audiences to understand about these programs and their importance is that they are vital for survival. This is not something that is just kind of a luxury or a nice to have. These are things that are sustaining life. These are programs that are vital to one's dignity, to one's survival, and without them, people will die. Right? It's not a question of, they might just live a little differently.
If we're serious about justice, about equity, then we have to be serious about care. And we have to listen to those who've been failed by the system most, because the cost of inaction isn't abstract. It's their health, their livelihoods, their stability, their futures.
I mean, I want to keep fighting for the rights of autistic people and disabled people, but I can't do it on my own. Not only do I need other disabled people and autistic people to fight about this, I want allies too as well. I can't just do this on my own. Disabled people can't fight on our own. We got to come together. And
this is just the beginning. Over the course of this series, we'll hear from people across the South. Disabled, multiply marginalized, and dual eligible, all navigating care systems that were never designed with them in mind. We'll ask how we got here. We'll expose what's broken. And we'll imagine what a just system could look like, one where disabled people can thrive, not just survive. Join us next time in Kentucky as we meet Jen and continue the fight to make care a right and not a gamble few can risk taking.
To learn more about Dual, the true cost of care, tell your Dual eligibility story, or to get involved, visit dualcostofcare.com.